Dr. Doughty, welcome.
Thank you.
Thank you for giving us a little bit of time to talk about the treatment of women with hormone-sensitive, hormone receptor-sensitive early breast cancer. You treat everybody the same way? Silly question.
And we don't treat everyone the same way. I think we are moving much more towards aromatase inhibitors rather than tamoxifen. And if we're going to use an aromatase inhibitor now, we tend to use it up front. But there's still people with small grade 1, node negative, strongly ER positive cancers that we would still recommend tamoxifen, or if they couldn't tolerate that, even no treatment, because the risk of recurrence is so low in those patients.
Premenopausal, postmenopausal?
No, all premenopausal tamoxifen, so there's no evidence for aromatase inhibitors. In fact, they may actually be harmful in premenopausal women. So postmenopausal AIs for the majority, tamoxifen still for low-risk patients.
Can you just run through the evidence base for that, the big trial, that sort of thing?
Well, I think the evidence, I mean, we've looked at recurrence and we found that virtually all cancers, grade 3, grade 2, node positive, have an early peak of recurrence, but the grade 1s don't seem to do that.
Oh, right.
And
so grade does matter.
Yeah, and that's also held up in the ABCSG that was presented in San Antonio, the sort of small grade 1 and 2s treated by sequencing. They didn't have an early peak of recurrence.
And what was the sequence in that?
The sequence in the ABCSG at San Antonio was tamoxifen and then Arimidex.
3 years of tamoxifen?
Two to 3 years, but it's a very... We've got to be a little bit cautious with that trial because it's only grade 1 and 2, so there were no grade 3, didn't have chemotherapy. Interestingly, there was a lot of elderly patients in that trial. The cut-off limit was 80, which is pretty unusual for a trial.
Yeah, sure.
But that was just for good outlook cancers.
Yeah. And the European trials?
Well, the 2 European trials, well, there's 3 big trials for upfront. There's ATAC, there's TEAM, which was presented in San Antonio, which is still very early data, and there's Big 198, and Big 198 has just been published in the New England Journal this month. And they're looking at, you know, aromatase inhibitors up front compared to tamoxifen. The problem is, you know, there's slightly different patient groups in each study. The primary endpoint of disease-free survival is different in the 3 studies. So until we have the result of FACE, which is hopefully going to report next year, which is the node-positive postmenopausal ER-positive patients randomised to Arimidex or letrozole, indirect evidence supports maybe one, maybe more effective, but it is indirect, and you do need that phase study, which will tell us definitely are Arimidex and letrozole are the same or are they different.
And the big 198 New England Journal article, for those who haven't read it?
Well, I mean, the big 198 data is the strongest data for the use of an upfront aromatase inhibitor. It was answering 2 questions. The first question was the sequencing results, so whether sequencing, so tamoxifen followed by letrozole or letrozole followed by tamoxifen was superior to monotherapy, and it was powered that way because in the metastatic setting, kind of sequencing often works better than single agent, so that's why they designed it like that. And the results of that were very, very interesting. They showed there was no superiority over sequencing, and actually the patients who got letrozole appeared to do better than tamoxifen followed by letrozole. However, you know, there were multiple comparisons. You had a 95% confidence interval. So it's not answered the question completely, but it's certainly given us interesting thought. The other very interesting bit of that paper was the letrozole followed by tamoxifen. Compared to letrozole, there was kind of no difference in early events, again, which is very interesting. So that was the first part of the trial. The second bit is the monotherapy 76-month analysis. And I mean, as you know, that trial was complicated because when the first results were presented at 26 months, the study was unblinded because the benefit of the patients on letrozole was so great. Better, and it's exactly like MA17. And that has caused controversy, but in this day and age, if patients are going into trials and one drug is clearly superior, I think we have a moral duty to tell the patients and give them the option. So 25% of patients initially prescribed tamoxifen elected to get letrozole. So they're included in the intention to treat analysis, and we know from every sequence our switch study, so IAS, ABCSG, ITA, if you start with TAM and then get an AI, you will do better.
Yeah.
So that will underestimate the true benefit of letrozole.
Yeah, sure.
But even despite that, you know, there was a much bigger reduction. It wasn't significant, but there were 40 fewer deaths at 76 months, absolute deaths, compared in the patients who got letrozole compared to tamoxifen. And in the ATAC 100-month data, there's only 5 fewer deaths at 100 months. Now, what they've done, it's not in the actual paper, but in the appendix online, I think it's Rich Gelber who's associated with the Big 198. They've done this analysis, the IPCW, which is very, very complicated statistically. But what they've tried to do is to look at the patients, take out the patients who opted to take letrozole. They've corrected for the baseline because obviously, you know, we know that more patients who opted were high grade, no positive, and they tried to correct for that. And if you look at it, the difference appears to be greater than in the intention to treat analysis. Now, they've not given a p-value, and that's the absolute right thing to do because there is going to be bias. Sure. But the confidence intervals don't cross 1, so it does look that the letrozole benefit is actually greater than we saw in San Antonio.
Is that a distant metastasis effect? What's your hunch on that?
Well, I mean, distant metastasis is, I think, what we should be preventing. And as a surgeon, I feel I've got an influence on local recurrence. I don't have any influence on distant met, so I think that's what we should be aiming for. And the difference between the two studies, ATAC and BIG, with the caveat that there are different patient populations, is that in BIG there was an early reduction in distant mets, a 27% relative reduction, and in ATAC there was no reduction seen until 100 months. And if you reduce distant mets, then you should improve survival, and clearly that's what's Big 198 is showing. Yeah.
And it's reflected now in the St Gallen recommendations?
Yeah, St Gallen, and I think in 2007 most of the panel were going for sequence, and in this year I think 70% of the panel, mainly because of the new big data from San Antonio, thought that you should start with an aromatase inhibitor.
Dr. Doughty, thank you very much indeed. I really appreciate you giving us the time. Thank you.